Welcome, everyone. We'll get started in just a moment. Welcome, everyone, and good afternoon and good morning to you. My name is Emily Bell, and I'm the director of the American Cancer Society National Colorectal Cancer Roundtable. Thank you for joining. We appreciate everyone's time and making an effort to engage with us in this program today. I'm proud to partner with the implementation science team at the American Cancer Society on this three-part webinar series focused on cancer screening for community health centers. Today, our focus will be on colorectal cancer screening, which is fitting given that we're rounding out National Colorectal Cancer Awareness Month this March. And as many of you know already, colorectal cancer screening saves lives, yet more than 1 in 3 adults of screening age are not getting screened as recommended. And while we've seen incredible progress with increases to screening in health centers, as of 2023, we know that just 4 in 10 adults served by health centers were up to date with screening. So with that opportunity in mind, our focus today is on providing resources, tools, and best practices to those of you working within and in partnership with our nation's over 1,400 health centers to support you in delivering more on-time and potentially life-saving screenings to the communities you serve. Next slide. In terms of our agenda, we'll start by taking a look at the current data and statistics around colorectal cancer, with a particular focus on the need to increase screening for adults ages 45 to 55, those that are recently eligible for screening. We'll then hear from Family Health Services, a health center in Idaho, to learn more about the phenomenal progress they've made in increasing screening rates. We'll share tools and resources to support your work. And lastly, have a conversation with a health center leader on prioritizing this work amidst all that health centers take on to improve the health and well-being of over 32 million people across the country. Throughout the program, please share your questions by submitting them in the Q&A box, and we'll have time for Q&A at the end of the program. We'll also be recording this session, and we'll make the slides and recording available to you through the NCCRT website in the next few days. So before we get started, I'd like to take a moment to hear from you to better understand your base of knowledge around colorectal cancer screening. So please take a minute to answer the 4 questions in the poll. Looks like some people are having technical difficulties with the poll. For our producers, is there anything that we can do to bring that back up for them?
I just relaunched the poll, so I think people should be able to answer again.
Okay, excellent. We'll take just one more minute to please share your answers. Okay, there we go. I see much more data flowing in. I always feel like this point is like popcorn. You're waiting to hear a few more pops, but waiting to see them slow down. Okay, great. Well, thank you all for taking the time to share your answers. Let's now close out the poll. And I'm really pleased now to introduce you to our 3 speakers in the program today. Rebecca Siegel is a descriptive epidemiologist at the American Cancer Society, where she is Senior Scientific Director of Surveillance Research and lead author of the annual Cancer Facts and Figures and Cancer Statistics article. She has published across the spectrum of cancer surveillance, but is particularly interested in racial disparities and colorectal cancer, especially early onset disease. She has been such a central figure in providing the data foundation for our work over the last several years. We're so grateful for all that she does to help inform our work. Anay Puente is a registered nurse with over 15 years of experience in family practice. As a regional charge nurse, she delivers high-quality patient care in a diverse population at Family Health Services, a federally qualified health center and patient-centered medical home in South Central Idaho, serving over 30,000 patients in an 8-county rural area through 11 locations. Family Health Services was one of our 2024 ACS NCCRT National Achievement Award honorees. It's been such a pleasure learning about their tremendous work. And then lastly, Dr. Heath Winfrey is the Chief Medical Officer for the New Orleans East Louisiana Community Health Center and an Assistant Professor of Medicine at the Tulane University School of Medicine. He serves on the Steering Committee for the ACS NCCRT and the Steering Committee for the Louisiana Colorectal Cancer Roundtable, the Clinical Committee for the Taking Aim at Cancer Louisiana Initiative, and the current Clinical Branch Chairman for the Louisiana Primary Care Association. His health center was our 2019 National Achievement Award Grand Prize recipient. And with him as well, it's been such a pleasure learning about their work and having an ongoing relationship to see how that work evolves. So now I'm pleased to turn it over to Becky Siegel to share with us the latest data and statistics around colorectal cancer incidence, mortality, and screening. And again, throughout the program, please submit your questions in the Q&A box, and we'll get to those at the end of the program.
Good afternoon, everyone. I'm really happy to be with you today. I'm just going to give a very quick overview of where we are right now with colorectal cancer incidence in the U.S. and highlight how it really underscores the importance more than ever of increasing screening rates, especially in those populations where they remain low. So in the US, we're estimating that there'll be more than 154,000 new cases of colorectal cancer diagnosed this year, and about 53,000 people will die from the disease. 44% of the new cases in 2025 will be diagnosed in people younger than 65. And this is all the way up from just 27% in 1995. Additionally, 21,000 of these cases will be diagnosed in people in their 40s or younger. And this is the equivalent of 58 new diagnoses each day in these young adults, which is quite a surprisingly large number. Overall, there's been a lot of progress in reducing colorectal cancer incidence and mortality because of changing patterns and risk factors like reductions in smoking and increased use of anti-inflammatory drugs. We also saw an acceleration in these declines during the 2000s because of the widespread uptake of colonoscopy, which really underscores the power of screening. Rates are higher in men than in women, but trends are very similar overall. And rates have been declining for incidence by about 1% per year over the past decade, and a little steeper for mortality, about 1.7% per year. And this is because of the additional influence of improved treatments. However, this progress completely masks the increase in incidence rates that's happening in people born after the 1950s. And so if we look by these large age groups here, we can see that rates are indeed declining rapidly in people 65 and older by about 2.6% per year. But at the same time, rates are increasing by about the same magnitude in people younger than 50. And then in this middle age group, rates are also increasing over the past decade by just 0.4% per year, but it's still a quite shocking turnaround because in the decades prior, rates were decreasing by 2% per year, mirroring those same patterns that we see in older adults. And the reason that this trend has changed is because generations born after 1950 have higher risk. So with every successive generation, the risk is a little bit higher. And so people who were born on the cusp of that, like I was born in the 1960s, so I have aged into this middle age group. And you don't lose that excess risk when you turn 50. You carry it with you. And so that's why these trends are really changing in direction. So there's a flurry of research happening to try to understand why the rates are increasing. But these results will probably take quite a bit of time. And so in the meantime, we can prevent many cancers and deaths through screening, because almost half of cases diagnosed in people under 50 occur in people who are 45 to 49. And we are now screening this age group. And so there's a lot of potential here. And then in addition, I think an underappreciated fact is that almost 30% of people diagnosed before 50 have either a genetic predisposition or, more commonly, a family history of either colorectal cancer or precancerous lesions at their colonoscopy. And so these people should have been screened even before 45. Although there were doubts about the efficacy of screening when ACS first lowered the age recommended to begin in 2018, many studies have been published since showing that the prevalence of precancerous lesions are the same in people in their late 40s as in their early 50s. And this is one example of one of these studies. So the 45 to 49 year age group is shown in red bars. These are people screened for the first time, and people 50 to 54 in the blue bars. And you can see that the prevalence of advanced adenoma and sessile serrated lesions are the same in these two age groups. And the other thing that this study showed that is important for many people who had concerns is that the volume of colonoscopy was only modestly impacted by adding this 45 to 49 year age group. And then this larger study that was published just a few months ago from Kaiser showed very similarly. These are people who had a positive FIT test, and then upon follow-up colonoscopy, people who were 45 to 49 had the same prevalence, again, of advanced adenomas and sessile serrated lesions as people who were 50, providing further support for screening. And then the NCI researchers also came out with this study last year that I think is really compelling. They were looking at the potential for screening to reduce cases and deaths from all the various cancers that have screening tests available. And they found that for colorectal cancer, and this is looking at for people who are just newly eligible for screening, so young generations, if we could take all of the young generations and get them to screening at 80% is what they use for colorectal, they determined that we would be gaining 4.4 million life years by the year 2045 and averting 360,000 deaths. And notably, this is the deaths averted is the largest for any screening intervention that they looked at. So I think that's pretty powerful. So where are we with screening? This slide shows up-to-date screening prevalence by age from 2019 to 2023. And we had some great news at the annual meeting in November. People 45 to 49 have increased their screening uptake to 34%. So 1 in 3 is current for screening now. So this is something to celebrate for sure, but quite a long way to go to get to the 80% that's our goal and that we've achieved with Medicare beneficiaries. And it's also very concerning that we only have half of people who are in their early 50s who've had a recent screening test, because this age group has been recommended to screen for decades. And one thing I didn't have time to show today, but I wish I had, is that death rates, colorectal cancer death rates, are increasing in people 50 to 54 and people under 50. And so we've got increasing incidence and increasing mortality. So really important to increase screening uptake here. And then, as we all know, most of the people who are being screened have health insurance. So the prevalence in this age group for people who are uninsured is only 14%. And screening is also quite low in people who identify as Hispanic, Asian, or Native American. And I want to point out, this is a different age group. It's not 45 to 49, it's 45 to 54. We had to aggregate those two age groups because of some low numbers for some of these populations. And so it's quite shocking that 2 out of 3 people who are under age 55, who are Hispanic, Asian, or Native American, are not current for screening. And one of the things I wanted to point out, both for these groups, as well as younger versus older people, stool testing is a really important option because they prefer stool testing, younger people, probably for the convenience factor. Younger people and people of color tend to prefer stool testing over other groups. So really important to include that option. But also why this is really concerning is that rates are increasing under 50. These are incidence rates under 50 for the 5 racial and ethnic groups that we were just looking at. Incidence rates are increasing for every group, and they range from increases of less than 1% per year for Asian people and Black people to 2% per year for white and Hispanic people, and 3% per year for Native American people, who have surpassed Black people to have by far the highest rates of early onset cancer. And then I wanted to end on a positive note. This is really exciting for us. We're actually seeing the influence of screening, even though the uptake remains relatively low. These figures show incidence rates for the 45 to 49 year age group overall, and then for localized and advanced stage diagnoses. So from 2018 to 2021, there was a 7% per year increase in localized stage diagnosis, which almost certainly is reflecting screening, because in the prior years, there was a decrease in localized stage diagnosis, and that's because these are usually asymptomatic cancers. And so this is not a population that's been screened previously. And so advanced diagnoses has been driving the trend. As you can see in this figure on the right, the rates are much higher, and there's still a steady increase in advanced diagnoses. But hopefully with greater uptake of screening, we can dampen that trend. So the bottom line is really simple. I hope this data has been convincing for you. We have an increasing proportion of colorectal cancer patients who are younger, and yet these are the folks who have the lowest screening rates among those who are eligible for screening. So now is the best time that we can focus on screening to increase rates in these groups. People of color and the younger age groups, really important to include the stool testing option. And I would say it looked from the survey like pretty much everyone is talking to their patients about screening, but I would urge you to have this conversation well before 45, because many people have a first-degree relative, a parent, who had an adenoma at a colonoscopy, and they should be screening before 45. And I also wanted to point out that a study came out just last week in Lancet, some of you may have seen, that if there's a 2-week deadline for the stool test, then the returns are higher than if there is no deadline given. So giving that stool test option with a deadline. And then the other thing I just wanted to point out, I always think about this, but it isn't talked about very much. The only other cancer where we have screening tests that can detect and remove precancerous lesions, so actually prevent cancer, is cervical cancer. Today, cervical cancer is the 16th most common cancer diagnosed in women, whereas in 1950, it ranked 3rd. And this is completely because of the Pap test. And of course, we have newer tests, the HPV test now, but really this success was driven by the Pap test. So there's a lot of potential here to turn these trends around. And I just wanted to thank cancer registrars everywhere who make this work possible, and my collaborators on this project. And I really appreciate your attention. Thank you.
Thank you so much, Becky. We really appreciate that. It was so insightful and provides such a great grounding for our work. So now we're pleased to hear from Anay Puente from Family Health Services.
Hello, everyone. I'm so excited to share our hard work with you guys for our colorectal cancer screening. Next slide, please. So Family Health Services is a federally qualified health center. We serve a rural area in South Central Idaho, and we have 11 different clinics that help serve the communities that are in need. We serve over 30,000 patients, and that includes patients that are insured by Medicare, Medicaid, have private insurance, or some that are uninsured. Currently, we have over 11,000 patients that are due or fit the criteria for colorectal cancer screening. Next slide, please. So as we started focusing on how we would improve our screening rate, we had to understand where we were at to start and establish goals. So here you can see that we have different clinics that were in various stages of screening. However, none were very high. So we definitely wanted to focus on increasing that screening rate. And to focus on it, we go ahead and go to the next slide, please. We had to start by setting our goals. So setting our goals included understanding we have to make the goals realistic, something that we can achieve to continue to motivate staff. And it really came around preventative screening education to everyone that is part of the team. So we set the goals, we communicated the goals, and then we set meetings to ensure that each clinic was equipped with the best way to achieve the goals. We ensured that all of the necessary departments were involved. So that involved receptionists, clinical staff, nurses, providers, and of course the patient. We also had a grants writer that really helped us focus on our efforts and really disseminate the information to the different clinics. The first step that we made was really getting our nursing staff or our clinical support staff equipped with the information so that they could share it to patients. We started with really addressing aggressive huddling and making sure that we identified the patients that we needed to optimize their time in the clinic with, giving them the recommendations that their appointment was a great way that we were able to find success. It was also a way that we were able to collect barriers that patients had, and it could go anywhere from patients who were uninsured or maybe patients that had Medicare but didn't have transportation. So it really helped us collect that information so that we could use it to find solutions for our patients. We noticed that the education that we provided to staff trickled down to the patients, so they were able to talk to the patients in a comfortable manner because they understood what our goal was and how important it was. We also tried different things like going from a 3-day fit kit to a 2-day. We saw that with a 3-day fit kit, we found barriers such as patients weren't returning them in time, so we couldn't process it. Patients would have to repeat it because it wasn't returned within the correct timeline. And then we also saw that Family Health Services was carrying a great cost because we had a lot of kits that were not being utilized within the correct time frame. So we switched to a 2-day kit, which it helped it decrease our cost, but also improved our return rate. We also, as Becky just mentioned, the deadline was something that we really had to give the patient. So we had a goal of completing the screening, but then letting them know that if they were mailing their fit kit back, we wanted them to have a 10-day time frame. That way they could collect both specimens and have the time for it to reach the clinic before the 14 days was up, or we couldn't run the test and had to continue to give the re-education and possibly mail out another fit kit. We also trialed providing free fit kits to patients. We thought cost was going to be a barrier for some of our uninsured patients. So we found, interestingly enough, that that was unsuccessful. One piece that went with cost was we did purchase stamps that we provided for patients to be able to return those fit kits back. And that actually turned out to be more successful than the free fit kits. And we also found that some of them didn't get returned. So in order to make it more cost effective for the organizations, we switched to a business reply mail where we would only have to pay for those kits that were truly returned. We had patients that didn't want to touch their stool, so we tried providing a sterile container to them, having them bring that specimen in so the clinical staff could run it. But we quickly found out that that was not an approved method to run a fit kit on. So we learned our lesson and we had to recall the patients that had completed the fit kit in that manner, and we had them redo it. We also initiated standing orders that helped with different hospitals receiving the orders that they needed, vouchers from different hospitals that helped for payment for the patients, and also patient assistance with things like Cologuard. We also utilized Family Health Services Foundation. We have a gala every year where we raise funds that we help utilize it for any patients that possibly had like a positive fit kit, but didn't have the resources to follow through with the recommended colonoscopy. And with that, we were able to collaborate with a local gastroenterologist, and they were willing to offer reduced cost colonoscopies, and that helped the funds within the foundation go a little longer, and also helped with those patients that maybe it wasn't as much of a barrier for their cost, but offering that reduced cost colonoscopy was an option for them, and we had a few that would take that. And then we focused on our providers. Again, we looked at, in those meetings, making them as useful as possible, using PDSA cycles and measured-based incentives to really motivate staff to focus on this. And providers also, that was kind of our second tier that we focused on. And we saw that their discussion with the patients was very influential. In the clinics, we had to figure out how we could do nonverbal communication where a patient would refuse the screening, and we would notify the provider so that they were aware before they went in with the patient that they were going to have to help us kind of further along the education. And also when they got records, making sure that they communicated it with clinical staff so the chart could be updated correctly. And I mentioned a little bit of competition. So next slide, please. To incentivize our competition, we had basically Pierre Lepoux, who acted as our trophy. Pierre would get handed off to the clinic that had the highest colorectal cancer screening rate for the month. And it actually proved to be a pretty fun way to have patients start asking about what was Pierre all about. We would put it in our waiting room and we would have patients start to ask the receptionist, which would kind of segue it into make sure you ask your clinical support staff if you are due for colorectal cancer screening. And he continues to live on. He continues to move from clinic to clinic of who has the highest screening. And then again, the quarterly measures that were tied to the incentive also were tied to not just where care went, but also the incentives that staff were getting. And next slide, please. So here you can see our overall progress comparing from when we started to our most recent data. And we overall started at 18% and currently our overall screening rate of 57%. Our highest clinic has a 65% screening rate right now. And so we're really just focusing on taking everything that we've learned and continuing to innovate and looking for opportunities that we can take to continue to affect our screening rate. So we've done things like implementing a Cologuard interface, making sure that we continue to audit the charts, sustain the measures that we saw were successful. We have our grants coordinator that is continuing to look for any other resources that we could offer to our patients, and care coordinators and referral coordinators that continue to follow up on those referrals that we're waiting for results, making sure that nobody falls through the cracks there. And then care coordinators that continue to reach out to patients that maybe haven't been seen, but they're due. That's just where we're at, continuing our efforts. And next slide, please. And I thank you all for your attention, and I hope that I've given you something that you can take back and implement to increase our screening rates. Thank you.
Excellent. Thank you so much, Anay, and thank you, Becky. Your presentations were so thoughtful, eye-opening, and inspiring. So we really appreciate you sharing with us. Before we move to our final speaker, I wanted to take a few minutes to share with you a few tools and resources available to support your colorectal cancer screening efforts in health centers. The American Cancer Society National Colorectal Cancer Roundtable has been at this work since 1997. We are the oldest of the American Cancer Society's 7 mission-critical roundtables, and we have a number of tools to support your work. So, next slide. So first, I wanted to point you to our resource center. If you go to nccrt.org, you'll see at the top level navigation, you can click on Resource Center. Here we include evidence-based resources and tools that have been produced by our organization in partnership with our members and our steering committee, as well as some that have been submitted by our members. So it's a one-stop shop to find resources. You can search by setting and specifically click on community health centers. You can search by target population if you're trying to reach particular facets of your community. Search for videos, infographics, you name it. So it's a great place to poke around, get to know what's available so that you can go there if you're setting out on a new quality improvement effort or new strategy. Next slide. And then a few tools that I wanted to call your attention to that are particularly useful for health centers include our clinician's reference on stool-based tests for colorectal cancer screening. This was initially published a few years ago and then updated just this January. It's brief, it's just 4 pages, and is meant to either introduce or reintroduce the value of stool-based testing to really make that case to offer the menu of options and not just to focus on colonoscopy as the only option. It includes the science behind the different types of stool-based tests available and some best practices tips for implementing a high-quality program. Next slide. I also wanted to share with you our STEPS guide for increasing colorectal cancer screening in primary care practices. This is perhaps our most used resource. It was actually initially produced in 2014 and aimed specifically at community health centers to provide a step-by-step approach for increasing rates. That was soon after health centers were first asked to report colorectal cancer screening as a UDS measure in 2012 and really wanted some of those tips and tools on how to get started in prioritizing this work. So it's a 4-step guide. You can go, soup to nuts, start from the beginning, or you can jump in where you're looking for more assistance. It also includes 10 case studies. 7 of those are based in health centers from across the country, and it includes over 200 pages of samples, templates, and tools. And I don't say that to intimidate you, but to rather, point out that there's no need to recreate the wheel. We really set about putting together this guide with a hope that we would include, everything you need to really ramp up your efforts without having to, start from a vacuum, but rather have something to work from. So definitely recommend checking out our steps guide. Next slide. And then lastly, we have a suite of communications resources that can support you in reaching out to particular audiences around colorectal cancer screening. We started our first market research project back in 2014, soon after the Affordable Care Act went into place, really with a motivation to better understand the barriers and emotional motivators that influence screening behavior. So each of these guides, the first one being a general guide, and then subsequent companion guides for reaching Hispanic and Latino communities, Asian Americans, Black and African American adults, each dive into understanding what does this community know about screening? What do they know about colorectal cancer? What are their emotional drivers? What channels do they like to get information? And then lastly, what tested messages resonate with them in influencing them to go on and get screened? Our most recent toolkit is called our Lead Time Messaging Guidebook. The purpose of this guide was to do market research in people in their 20s and 30s and early 40s to understand, what do they know about colorectal cancer screening, the importance of getting evaluated for symptoms if they appear before age 45, about family history, and then again to test messages to understand what messages can be put out there to really drive them to get screened on time, right at 45 or earlier if indicated. So great resources to use. Everything in here is meant for you to rip and repeat. So you can take these tested messages, use them in in your clinics, in your social media, and we love to hear stories about how you've used them and what successes you see. And then lastly, I just wanted to mention we have a resource on the horizon that should be published in May around best practices for reaching rural communities. And that will also highlight case studies, and 2 of those being health center settings. So in order to check out our resources and get on our newsletter list to find out what's coming, I encourage you to go to nccrt.org. If you scroll to the bottom of that homepage, you can plug in your email, and then you'll be added to our newsletter, which comes about every 2 weeks. It includes recent resources, webinar opportunities, and other member and partner events and programs that might be of support to your work. Next slide. Great. So with that, I'm now pleased to welcome our final speaker, Dr. Heath Winfrey, who's here to share with us insights into prioritizing colorectal cancer screening in community health centers. As I shared previously, Dr. Winfrey is not only the CEO of the health center, he also serves in numerous leadership roles to guide colorectal cancer screening efforts, both in Louisiana and on a national level. And it's been a pleasure to get to know him since he first became an award recipient 6 years ago. And we're so grateful for his ongoing generosity in sharing with our members and partners across the country about how health centers play a critical role in our shared goals to increase screening and the practical best practices and lessons learned that inform this work. So we have a few questions for you, Dr. Winfrey, and would love to hear your perspective. So welcome.
Sure. Thanks, Emily. Thanks for having me here, and I'm glad to be here. And I've enjoyed so far what I've heard from Rebecca and Miss Puente. It's been an exciting webinar so far.
Great. So we're curious to know what advice do you have on how to prioritize colorectal cancer screening in health centers?
Yeah, one of the main things I would like to say for our viewers, particularly those who work in the community health center setting, is that colorectal cancer screening is an opportunity for us to have success and wins, right? As an FQHC, our mission, our focus is to improve access to underserved communities and improve healthcare outcomes in underserved communities. And colorectal cancer screening, if done correctly, gives us the opportunity to have that success. We can actually touch lives, change lives, improve screening rates, particularly in those communities that have the lower screening rates, and see improvements and see lives saved. Just recently, within the past 2 weeks, we had a patient who we've been offering her screening for the last 9, 10 years, and she had a positive stool-based test for the first time in the last 8 years. Sent her for a colonoscopy. She was found to have 20 polyps. One of them was 40 millimeters in size. Fortunately, none of them seem to be cancerous at the moment, but just another example of how likely had she gone further without screening, one of those probably would have developed into a cancer, and it probably been a different outcome. So we do have opportunity to have success and wins and save lives if done correctly.
That's such an incredible story and testament to the power of screening and what we can do. And I completely agree. I've often heard people say and agree that colorectal cancer screening is low-hanging fruit. If only 4 in 10 people in health centers have taken on screening, it's such a great way to see those gains and have success. And we've often heard of health centers using a focus on colorectal cancer screening to apply to a quality improvement effort. So whether that's working towards patient-centered medical home or another effort, it's a excellent one to take on. And of course, we have the resources and tools to support the work too.
Absolutely, absolutely.
So, Dr. Winfrey, what do you see as the greatest opportunities and challenges health centers are facing when it comes to colorectal cancer screening?
Yeah, I think from a lot of the health centers I've talked to, and a lot of the medical directors, I think the major challenge is developing an organized, programmatic approach to screening. Many health centers just feel like this could be another task or measure that they have their providers focus on individually. And so they'll just bring it up in their providers meeting or their team meetings that, hey, providers need to do a better job of screening, and they just leave it on the provider's shoulder. But what we've seen both in research and in actual practice in the communities is that organizations that are most successful are the ones that develop an organized programmatic approach, meaning that they develop a team that is focused on the data, identifying individuals who are at average risk as well as high risk, educating the providers on the screening strategy that they're going to do as a organization. Now, of course, and realizing and giving that provider the flexibility that if you have someone who is high risk, if you have someone who's ready, maybe for colonoscopy, to go ahead and push that measure. But if you choose a screening strategy that's, let's say, not a colonoscopy, more of a stool-based strategy, then having the providers endorse that and embrace that as well. Most clinics and organizations that are struggling to get their rates up are really just leaving the option up to the providers to make it happen. And those are the ones that it just doesn't work as well if it's left just to the providers. So that would be my first recommendation of overcoming the challenges: developing an organized programmatic approach and making sure everyone on the team is involved, and make sure that you're using multiple evidence-based interventions. We've tried a host of them and realized that we were most successful when we were implementing multiple interventions at one time and ensured that our providers were making the recommendation and was on board with our screening approach.
That's great. Thank you for sharing that. And, I'll say among our awardees over the years, we have 5 awardee organizations each year for the last 9 years. I think that's been a common thread, seeing, that this is a team-based effort, getting all staff members on board in a health center or another primary care setting is really crucial. And then they can all share in that success too and feel pride in their accomplishments as well.
Absolutely, absolutely. Just like we started our earlier presenter, right? They had a little competition, and each site was involved in it, and I'm sure they were proud to have Pierre Lepoupe be a part of their waiting room. So yeah, the competition helps, as well as just the pride in knowing that collectively, here we are collectively making a difference. And that's what we see many times. Not only your providers, but many of the staff that work in the FQHCs are there to make a difference. That's what brings individuals to an FQHC setting, right? This is an underserved area. This is an area that has a lot of needs, a lot of challenges, a lot of barriers. And so to be able to contribute and make it a difference, to find one barrier that you can overcome, one challenge that you can overcome, really helps the organization to feel a sense of pride and confidence that we are making a difference in this community that we're serving. And so this is a great opportunity. Colorectal cancer screening is a great opportunity to do that.
Absolutely. I couldn't agree more. And then lastly, what advice do you have on how to use the resources available through the NCCRT or through ACS in guiding work in health centers?
Yeah, I suggest just going ahead and cracking it open. I mean, for us, the STEPS guide was very instrumental when we first began. With our story, you know, we started in 2012 when colorectal cancer screening was first introduced as a UDS measure. We had also just onboarded to a new electronic health record. And so when we pushed out our first report, it showed a 3% screening rate. We went back and later did an audit and found out that we were closer to like 10%, but it was still a very, very low screening rate. And at the time, much like I was sharing earlier, we just put the burden on the providers initially. Hey, here's the screening rates. You need to do better, you know, get with your MA and develop some standing orders and let's see if you can improve it. And while we had like a minimum improvement, it wasn't significant. And so we just kept trying to do our own, take our own steps and measures to improve screening. And it wasn't until I began doing some literature searches and looking for other examples of success in research that I came across the STEPS guide and other research that ACS had done, which really identified improving screening rates and more specifically improving them in colorectal and FQHCs. And that was the thing that really impressed me the most, is that there was an entity that actually looked at the challenges of offering screening programs in a FQHC setting or community health center setting and outlined steps and a guide to help you improve it. So I was like, you know, Keith, why are you wasting time trying to reinvent the wheel? Like an organization's already developed that for you. Just go through it, implement it, and let's save time in beginning your work. So I would encourage anyone who's just starting or trying to identify how they can improve, take a look at the STEPS guide. It lays out major steps to improving your program and gives you an organized approach to begin with. And then as you go on, you'll notice that some of it will be low-hanging fruit. It's just a matter of reminding patients and making sure the message is consistent, whether you're talking to a medical assistant, a patient navigator, a provider. But other times you'll notice that it will take a little more counseling and strategy. And so I saw in the chat box, someone mentioned motivational interviewing. That's most definitely a part of high-performing health centers, is that you have to have a degree of motivational interviewing and some flexibility and pivoting that takes place, because you're going to talk to patients that are just resistant or stubborn, and you have to be able to pivot your message, pivot your approach to the patient to kind of appeal to either their perceptions, their fears, their anxieties. And so understanding what some of those barriers are important. So for us, once we moved past the STEPS guide, we started using the communication guide. And that helps you to learn which messages will be most effective depending on the degree of apprehension that you're getting from your patient. Right? Some patients, it's just the fear of the colonoscopy. Whenever they think of colorectal cancer screening, they're thinking just colonoscopy, and they don't want to do it no matter what you say, no matter how you present it. They just don't want to do a colonoscopy, period. And if that's where you in the discussion, then the patient walks out of the room feeling like, you know, it'll be on their mind, but they still won't move forward towards screening. And so one of the recommendations of the communication guide is to let them know, hey, there's more than just one option for screening. If you're not ready for colonoscopy now, there's several stool-based, you know, very cost-effective tests you can do at home that also, if done properly, can still be effective at reducing your risk of developing colorectal cancer. So just knowing how to pivot and adjust your message depending on the patient that you're speaking with to be able to appeal to either their fears or their sense of self-efficacy can make a difference. So STEPS guide, communication guide, I think are main two. And then also now we're starting to lean more into the lead time messaging. As Ms. Siegel shared earlier, we have to start talking to patients much earlier than 45. Like we can't wait to 45 to begin the conversation. And most health centers, our largest population are patients between the age of 20 and 49, and they're African American, Hispanic, Asian, Native American, like these populations that aren't being screened. But we're also seeing these younger individuals in our health centers. Like that's our largest population. So just beginning to share that message, also letting them know some of the symptoms of colorectal cancer so that if they begin to recognize some of these symptoms, even though they may not be of the screening age, they still need to bring that up so that we can move on it. So for me, I think the STEPS guide was first, communication guides, and then now lead time messaging would be like the top three that I would say are most beneficial for someone who's just starting out, just not knowing where to start, where to look. I would say start there. Of course, there are more guides like the patient navigation, tool is out there, the colonoscopy calculator. Like there are many other tools that are out there, but these would be the first three that I would recommend because of the benefit they've had in our organization.
That's so helpful. Thank you. And we're at time. We'll move on to Q&A, but I just wanted to close out by asking if you wouldn't mind sharing your percentage increase that you've had at Noella, since back in 2012 until
Sure. Right. So I mentioned that we started around 3 to 10%. We actually reached 80% in 2018. And that was after implementing, like I said, multiple interventions and really staying after it year after year. The FIT screening was what we used as our approach. Since then, we've remained in the mid to upper 70s and actually reached 80% again in 2023. So we reached 80% twice, and now we hover somewhere around 74, 75%. For us, the challenge has been, we started with the FIT test. It was one that was, again, simple, easy. We could offer it in the exam room for patients to take home. We could mail it out to their house. But the challenge has been that every year you have to do it again, right? So you can have success that year, but then the next year you start over from scratch at 0. And so now we're looking to move on to maybe the multi-target stool DNA, where you can at least buy yourself 3 years in between, or moving those to colonoscopy for those patients who are ready. But yes, we've now been somewhere around 74, 75% on average, and have reached 80% twice.
That's fantastic. And especially given that the denominator has increased now that we're, collecting data for patients ages 45 to 49 as well. Dr. Winfrey, thank you so much. We continue to learn so much from you and really appreciate you taking the time to be on the program today.
Sure, absolutely. Thanks for having me.
Thank you. So with that, I want to invite all of our speakers back on camera. We've got a few questions that we can share with each of you. So first, a question for Becky around the data that you shared around race and ethnicity. We had one participant ask around, why are the screening rates so low in the different racial and ethnic groups? And then another that asked, would the data be more robust if we collected racial and ethnic data differently? For example, Asian Americans as one group versus disaggregating that data. I'm just wondering if you had anything to share on those two questions.
Yeah, so in terms of the last question, it's increasingly difficult to provide data, especially, I don't know if any of you are hearing about the issues with the census, the 2020 census, but we aren't going to have access to bridged race anymore. And what that allowed is, because so many people now identify as multiracial, that group is getting larger and larger, and those folks are left out if we don't put them somewhere. And so the National Cancer Institute had an algorithm for grouping people who are multiracial or who were missing race. They would use other factors to try to figure out what that was. But now going forward with the new census information, even that's not going to be possible. And so I think it's going to become increasingly difficult to provide that kind of data in the long term. But in terms of the screening rate. So the question was why the screening rates are so low by race and ethnicity versus by age. And those are just, they're completely different. So that those age specific groups were, you know, separate for 45 to 49 and 50 to 54. And then we had to combine those. And so when you combine it, if you looked overall, it would be somewhere between the 50% and the 34% overall, but then when you look by the specific racial and ethnic groups, then it looks even different. And so indeed, we know that if we looked overall, the racial and ethnic groups would have lower screening prevalence, which is why Dr. Winfrey's focus there on targeting those groups is so important.
Great, thank you. That's helpful. I think we have time for one more question for the Anay. We had somebody from the audience ask, can you provide more information on the 2-week return communication for FIT test? Was it a direct conversation with patients, voicemail, text messaging? How was that done?
Absolutely. So it all started when we would give the FIT kit to the patient, because we know that once they collect the first specimen, it must be processed within 14 days, right? So it was letting the patient know that, but then as we started to see that we would get those kits back potentially after the 14 days, we decreased that timeline to the patient so that we had time for it to be processed through the mail and get to us on time. So learning that, we started to tell patients, you know, once you collect the first specimen, the second one needs to be done within 10 days and you have to mail it back to us. Or letting them know if you're coming up closer to that, you know, 10 to 14 days, if you have the time to come and drop it off, that makes sure that it's still good and we can still run it. So it started with the education to the patient when we gave them the kit. And then we also followed up on those orders that we had pending that we hadn't received the kit back for. So we'd call the patient and just remind them, hey, we've got this kit that we're waiting for results to come back from you, or the actual kit to come back from you so we can process it. And then giving them a time frame, because if you don't say, I'm going to call you back in 2 weeks if we don't receive it, we're going to just keep having that order stay open. And we saw a lot of patients would probably, to avoid getting called again, they would get those kits returned to us if we gave them that 2-week time frame, and really asking if that was realistic, right? So if the patient would tell us, you know, I keep forgetting, I just put it in my cupboard in the bathroom and I forget, then we make a plan with them. Do you think you can get it in the next week? If not, what are the barriers? Do you think you can get it in the next 14 days? And we really focused on those 14 days because that's what the kit gave us, and just time efficiency for staff. To limit those orders that we had, and expectations. Once you communicate the expectations to everybody on board, you know, if I don't return that kit, they're going to be calling me back and I'm going to have to come up with another reason and another plan. So that's what we saw was very successful, because we started at the beginning and really followed through with it.
That's helpful, thank you. And I'm intrigued by the study that Becky referenced around a 2-week deadline for returns as well. So we'll look for that and try to share it in our follow-up email as well. We have so many questions, and unfortunately we just don't have enough time for all of them, but we'll comb through and see if there's anything further we can provide by email. I know there was a question around resources in non-English languages, and we can certainly share links to American Cancer Society resources in that follow-up. So before we close out, we wanted to take a moment to bring that poll back up again and see how your knowledge base has changed. So please take a moment to respond to the poll. Great. Well, thank you for taking the time to share. can move on to our next slide. So just in closing, I wanted to share a few calls to actions. We encourage you to make use of the resources we have available to support your work. Go to nccrt.org and scroll down to the bottom to enter your email and sign up for our newsletter and visit the Resource Center. Identify ways to prioritize screening. So, Dr. Winfrey and Anay had great perspectives to share on how to do this work within health centers. We love to hear about your work. So as you see successes, keep an eye out for our awards, call for nominations for our awards program every fall. It's really gratifying and exciting to see screening rates increase in health centers, and we want to continue to learn from you on that work as well. Lastly, our session 3 will be around breast cancer screening in October, and registration information will be made available closer to that date. Next slide. And lastly, we wanted to share a huge thank you to our funder. The program is supported by the Centers for Disease Control and Prevention of the U.S. Department of Health and Human Services as part of an award funded by CDC and Health and Human Services. The content shared are those of the author and do not necessarily represent the official views, nor an endorsement by CDC, HHS, or the U.S. government. And thank you so much. We really appreciate your time and have a wonderful rest of your day. Thank you.